Hi everyone, thank you so much for joining and sorry for the slight delay. It's really lovely to see so many of you here. So just a couple of ground rules for the talk. If I can ask that you all please stay on mute for the duration so that we can hear Brendan talking. We will be recording as well today, and that's started. If we can also ask if people wait till the end of the presentation to put their questions in the chat box, because as you can see, there's a lot of people here, which is really wonderful. And we want to make sure we don't miss any questions. So if you could wait till the end of Brendan's talk and then start posting your questions in the chat. And because there's so many of us here, we won't necessarily be able to get through all the questions today. But we'll try to get to as many as we can. But if you have any questions that don't get answered or more specific questions to your personal experience, then please get in touch with us after the chat on the helpline or the live chat or the online form on our website. And the last thing as well is that you'll be getting an evaluation after the session. So if you could all complete that, it'd be really helpful because it's really good to know what we can improve and what's gone well. And with that, I will pass you over to Brendan, who will do his talk now. Thanks, everyone.
You're just on mute, Brendan.
Is that better? Can you hear me?
Yes. Yeah, we can hear you. Yeah.
So welcome everybody, and thank you to the Migraine Trust for inviting me to speak to you about new medicines in migraine. And I've called it 21st century migraine medicines because hopefully we'll see more of this happening and improvement in the care of migraine. So what I'm going to try and do is cover quite a lot. Without further ado, I'm going to get into it. We're going to talk a little bit about these new therapies, what they are, what they do, how they potentially work, how they help patients, and then what to do when we have problems. And at the end, I'll probably take some questions on what's called combination therapy. I'm not going to talk much about that tonight. So how do they work? Well, calcitonin gene-related peptide is a protein, a peptide, which was identified 20 years ago by a gentleman called Peter Goadsby and Lars Edvinsson, where they took blood from patients having attacks of migraine. And they found that this protein is intimately involved in giving people migraine attacks. CGRP protein is in the brain, on the sensory nerves, in the blood vessels, and several specific structures which are important in migraine pathophysiology. CGRP is a very potent vasodilator. It makes blood vessels swell. And if you infuse CGRP into a migraine sufferer, they found that it induced a migraine within 24 hours in at least 80% of sufferers. And they identified over the last 20 years that if you blocked this protein with a variety of medications, then you could abort migraine attacks in the acute phase and also reduce the frequency of attacks in terms of people who are having frequent attacks. So, where does it work? Well, it works outside the brain. It doesn't work inside the brain. It works in a place called the trigeminal ganglion, and it works via a receptor. And I'm not going to talk huge amounts about the pathophysiology, apart from to state that the protein is in the bloodstream and around structures within the brain, but it has to interact with a receptor. And the importance of that is there are two types of drugs. Something which blocks the receptor, so a drug which stops this protein binding to the receptor, and there are drugs which bind to the protein as it is involved in the fluids around your brain. And those are the two main mechanisms why that explain why drugs against CGRP work. So before you think about these therapies, you probably need to think about what kind of migraine you have. There are two main types of migraine with and without aura. And then we define migraine as to whether you have episodic migraine and chronic migraine. And chronic migraine describes people who have headache more than 15 days a month and have had it like that for at least 3 months, of which at least a proportion of them, often more than half, are migraine-like, sensitivities to light, noise, nausea. I'm sure I don't need to teach you to suck eggs. Episodic migraine is classified as people who have headache less than about 14 days a month. And this is a really arbitrary definition. It doesn't really matter whether you've got episodic or chronic migraine, it just defines your frequency. And as you probably know, the more frequent your migraine is, the more impactful your migraine is, the more sometimes difficult it can be to treat. So before 2020, we had a large number of therapies that were good, and I'm not going to talk about all these. I'm just going to talk about some oral meds, some infusion meds, and some injectable medications, because that's where these drugs work. It's probably useful for you to be aware of the concept in migraine care in the UK. In the UK, if you see somebody with your migraine, you're likely to see your general practitioner first. And what's the current standard of care and pathways within the NHS is that we would expect a GP to start something called a first or second line or third line oral medication in the community. And most of these are things like beta blockers or amitriptyline or nortriptyline, tricyclics. So before you become a candidate for these new drugs, you have to have had at least 3 previous preventatives for migraine. You can have other therapies, but they usually have to be evidence-based therapies for migraine. The drugs themselves work in different ways. One of the groups of drugs is called a monoclonal antibody, and the monoclonal antibodies are given in different ways. 3 of them are injections, Raynaud, fremonazumab, and galcanezumab, and they're given either 4 weekly or monthly. And one of them is an infusion, which is given over 30 minutes every 3 months. Since these were developed, and we've had studies, NICE has now approved all 4 drugs for migraine. So there are now currently 4 different anti-CGRP monoclonal antibodies which are available in the UK for migraine. The earliest was Raynaud, and eptinezumab, the last one, is the most recently approved in March 2023. So access to these drugs is available everywhere if you meet the criteria. So how do you know if you're eligible? Well, if you have troublesome migraine, whether it's episodic or chronic, and you fail to benefit from at least 3 previous oral preventatives, you are potentially eligible for this drug. Where will I get them? Well, your GP will not be able to prescribe these. You usually need to attend either a specialist headache clinic or a secondary care clinic where you might see a neurologist. And it's variable coverage over the UK. So sometimes you might need to be sent out of your region to another area, to another regional clinic. If there isn't a headache clinic close to you, or you haven't got, you don't meet eligibility criteria, some people seek provision in the private sector. Which one of these drugs will I be offered? Well, actually, it depends upon your local service. It can sometimes be clinical factors. Some of the drugs cause constipation. Some of the drugs have some slight injection site reactions. So we tend to use another medication if you have some of those risk factors. But lots of the reasons for the drug you get given will be determined by your local headache pathway, or actually the relative cost of the drug, because your local healthcare provider might have determined which of the drugs is available to you. You should always discuss the different options. So what's the difference in terms of their effectiveness and how to assess them? Well, they're all pretty much the same. If you have episodic or chronic migraine, you've had at least 3 previous oral preventatives, and you're given one of these drugs, there's an expectation that you will have either a 30 or 50% reduction in your monthly migraine frequency or monthly migraine days in order to be considered responder. And most services should start drugs, probably with some baseline headache data for about a month, give you 3 treatments, and then look to assess you again at 3 months to determine you're a treatment responder. And if you're a treatment responder, you should expect to probably have that treatment for at least a year with annual review as to whether you still need it. Who can't have them? Well, if you're pregnant or planning conception, you shouldn't be given these drugs. We don't know the safety of these drugs. If you're planning conception, there needs to be at least 5 months before you should be considering conceiving, because of the half-life of the drug stays around. We're not aware of any pregnancy-related issues or teratogenicity, but because these drugs are new drugs, we have to be more cautious. If you have active cardiovascular disease, so if you have active angina, if you had a recent heart attack or stroke, it's highly likely you won't be offered that drug in the short term, but in the longer term, if this becomes stable, then you might be offered these drugs. These drugs don't cause heart attacks or strokes, but the outcome if you had a heart attack or stroke might be worse. Why, if I have episodic migraine or chronic migraine, will they not give it to me? Well, actually, most of the time, it's because you haven't had enough prior therapy or your frequency is wrong. If you're having migraine days once or twice a month, you could probably get away with taking an acute medication only, and you wouldn't necessarily treat somebody with one of these injectable therapies. Often, however, the case, as the Migraine Trust has identified, is there might be no service locally, or actually, some people just want to start a new modern drug, whereas their current therapy is working well. So there's no indication to change in that situation. So what does the data show? Well, I've just showed a number of graphs here, and these are different studies done over several years for all the drugs. And what you can see from what I've circled is, in general, individuals have about a 45 to 55% reduction, 50% reduction in monthly migraine days in about half the people who have these drugs. So you should expect, if you're a treatment responder, to have about a halving of your monthly migraine frequency, whether you have if you have episodic migraine within 3 months of starting this drug. It varies, obviously, according to individuals. Some people have more, some people have less. If you have chronic migraine, then the frequency response is fairly similar. And actually, in the studies, it was sometimes as low as 30% of people having a 50% treatment response. And in some of the other studies, 60% of people having a 50% treatment response. And that really depends upon what happened in their placebo group. But really, what these graphs show is most of these drugs are very similar in their effectiveness. And just because you get offered a Raynaud or fremonazumab doesn't mean you're missing out because it's a different monoclonal, because the efficacy response is fairly similar across all of them. How long do they work for? Well, we've been using these drugs now within our service for about 3 years. There's safety data for at least 6 years from studies. And what's really gratifying in these populations is that the treatment effect appears to be sustained. So these are long-term outcomes in people with chronic migraine and episodic migraine. And you can see that the treatment response, reduction in headache days and migraine days, is usually quite early, within the first 3 months. But if people keep on taking these drugs over at least 12 months or longer, you often see a slow drift down of migraine frequency in populations of people with episodic and chronic migraine. And in some people at 2 and 3 years, we're seeing absolute remission, allowing them to come off medication. But those studies didn't look at populations with severe migraine. They looked at people who'd only had 1 or 2 drugs. So further studies have gone forward, and there are 4 of them on all of these drugs, looking at people who've had at least 2 to 4 preventatives. So that's the population that we tend to treat in the UK on the basis of NICE guidance. And the responsiveness is fairly similar, which is gratifying to see. Diaries again show that about people who get about a 50% response is slightly less in people who've got more severe migraine. But actually, if you take it through and you look at real world data and you follow them over time, at 1 year and at 2 years, about 50 and 60% of people were having about a 50% response. So again, really important to note that people in the clinical trials improved in their treatment response the longer they were on the drug. So what happens in the real world? Those are clinical trials, but real world data is sometimes better than clinical trials. Well, actually, when these drugs were rolled out, and this is a London group who looked at their first 6 months of treatment data, we found that actually about 60% of people had criteria at 6 months which allowed them to continue, who didn't necessarily respond as well at 3 months. At least a third of people having failed on at least 8 prior therapies. So these are people with really bad high frequency migraine who've tried pretty much everything before these drugs had come along. They had Botox, 90% had failed. But despite having failed on multiple drugs, these new anti-CGRP monoclonal antibodies give a really useful treatment response in at least a third to half of them. And you can see from the data, 1 in 5 of people who'd failed on multiple drugs had a 75% reduction in migraine frequency. Life-changing for many people. And I don't think I've heard the word life-changing more in any time I've worked in the migraine field previously. Life-changing, I've got my life back, has been routinely quoted to me. This is our data, and it shows again that only about 10 to 15% of people had no response at 3 months, suggesting at least 70 to 80% of people had some response in their migraine frequency over the course of 3 months, going up to 12 months. And a good 5%, so 1 in 20, having almost complete remission by 12 months. The data is the same all through the world. And the trends is that if you're given these drugs, there is a good 1 in 2 chance of you having a 30% reduction and therefore having sustained treatment, meeting criteria to continue on therapy. There's a good 50% chance that you'll have a halving of your frequency over the first year if you're a treatment responder. Sometimes the treatment effect is lost. And we've seen a number of people over the course of treatment over the years who sometimes have been really stable and then something has made their migraine worse. And the commonest thing we've found over the last 2 years has been COVID-19. People contract COVID-19 and then their migraine becomes worse. It settles down again and the treatment starts to take effect. If you overuse triptans, it is not a barrier to care with these treatments. People who overuse triptans in this group often are more sensitive to the treatment effect because triptans work on CGRP. The fact that they work in reducing CGRP and are effective for your headache problem in some ways is a positive predictor that you might be a treatment responder to these new monoclonals. We don't, however, have much data on what kind of treatment response you have if you take too many opioids, so cocodamol, coproximol. And there's still studies to be found to find out whether people who have opioid medication overuse headache with their migraine have as good a response as people who have triptan overuse. So what should I expect from my treatment? Well, when I have this treatment, you should at least expect a third less attacks for it to be considered effective. I would hope that you'd have at least a 50% reduction in attacks. We would expect to see a reduction in your triptan usage. We'd expect your triptans to possibly become more effective. We'd expect the tolerability to be good. At least 90 to 95% of people don't complain of any side effects with these drugs compared to the previous drugs they might have had. But we do see some people have no response. And if you're a non-responder, the 10 to 20% in our practice, it's probable that you don't have a CGRP mechanism which is driving your migraine. And what's been really interesting across the country is that the outcomes with these treatments are much better than NICE predicted. So actually, the healthcare costs for this have gone up, but actually patients have got better, which is really what we want to see. How long will you need them for? Well, you need them for a minimum of 3 months. Most people, if they respond at 3 months, maintain that response at 12 months. And we have patients now who've been on these treatments for 3.5 years. When we were modeling how best to use these therapies in conjunction with NICE, NICE looked at a 40-year time horizon for treatment. So theoretically, if you have really bad migraine in your 20s, it's potential that you might be on these kind of treatments for a long-term period. But we don't really have enough data yet to determine that. But we wouldn't expect it to be the rest of your life. And sometimes local pathways determine when you have to stop. So what happens if I don't respond to one of these drugs? Well, there's no data on non-response, and I've just quoted a German study. If people don't respond to anti-CGRP monoclonals, it's worth switching to a different one, because there's a 1 in 3 chance that you will respond to a second anti-CGRP monoclonal antibody. As I just said at the start of my talk, a Raynaud or Aimovig works on the receptor. It blocks the receptor. Whereas the other three drugs, they bind to the protein as it, for want of a better word, swims around within your body. So if you've been treated with erenumab, it's highly likely if you'll be changed to a different mechanism, something which attacks the protein. And if you've been given something which attacks the protein, fremonezumab, galcanezumab, or IV eptinezumab, you're probably going to be changed to erenumab. So we're looking at different mechanisms. We don't really know with certainty what happens if you fail on 2 different monoclonal antibodies. We think you're probably not going to respond to a third one, but there really haven't been many publications suggesting that a third one is not the right thing to do. What we would do in our clinical practice, if you'd failed on 2 injectable monoclonal antibodies with different mechanisms, we would probably move to the intravenous formulation because we know that gets into your body and system quickly. So if you failed on 3, then you're very unlikely to have a CGRP-related mechanism with your migraine. And what's really interesting, if you do switch monoclonals, having not responded to the first one, not only do 1/3 of responders benefit from the switch, 1 in 8 have a significant benefit in terms of their migraine frequency. So don't lose heart if you don't respond to the first anti-CGRP monoclonal antibody. You should certainly request the second. And it's important that your local pathway doesn't prohibit you from obtaining a second anti-CGRP monoclonal antibodies. As some parts of the country, regrettably, have put barriers to care in terms of obtaining that second dosage, that second drug. How long will they need them? Well, we're still treating people at 3 years. I'm expecting to be treating people for 3 to 10 years. The big problem is capacity because there's not enough people in specialist centres, let alone enough to kind of deal with the increased numbers needing follow-up. So I would hope in the longer term, we'll see this being delivered in primary care and followed up in primary care. When do I stop? Well, actually, if you're a non-responder, you stop at 3 months. If you're a non-responder at 12 months, your neurologist will probably suggest you stop then. But actually, if you're still having migraine at a frequency where we'd probably consider starting a preventative, there's no reason to stop. And NICE didn't set any stopping criteria when it set out its evidence. So it's up to the clinician treating you to determine when you should stop. And there are often, again, local guidelines around how one does this. What we do in our service is that we increase the time between injections rather than absolutely stop it. So what happens when you stop? Well, actually, once you stop the anti-CGRP monoclonal antibodies, there's a 1 in 3 chance, a 33% chance of reverting or relapsing back to your previous migraine frequency within about a month. And certainly half the people who relapsed did so within 3 months. So if you haven't relapsed back to what you were like beforehand within 3 months, you probably have had some relative remission in your migraine. There's certainly about 10% of people who go into complete remission. And we're seeing that with longer term therapy up to about 2 years rather than at 1 year. So why is everywhere a little different? Why do I live in one part of the country and they won't give it to me and they won't do what you're doing, Dr. Davies? That's because headache services are really driven, dependent on how they interpret the local guidance, how they interpret NICE guidance. And actually, when you read the NICE guidance, there are lots of areas of uncertainty and vagueness. So it gives some principles, but it's a question of actually using some common sense and engagement. What I say to my colleagues in our team is if someone comes into the clinic and they're doing well on their monoclonal antibodies, I ask the question, if you were coming to see me with your current migraine frequency, would I start treatment for you? And if the answer to that question is yes, there's no reason to stop. So in the patient who might come in with 2 or 3 migraine days a month, they might just get away with taking an acute medication. So I might not want to give them a daily preventative or a monthly preventative. But if that person's having 4 to 5 migraine days, needing to take triptans, then it's really important that that person continues on that therapy because they've got active migraine, which would benefit. Shared decision-making, like anything, is good practice. What are the risks of this drug? The risks of this drug so far have not been massive. There are minor side effects. Injection site pain with some of them, upper respiratory tracts, sometimes some redness around the injection site, what's called hypersensitivity. But that, in our experience, is seen more with fremonazumab and has not been sufficient to stop the drug. The main concerns around this has been the development of something called Raynaud in some people, very rare, and the risk of wound healing potentially with if you're having operations. So sometimes we don't start medications if you're about to have an operation. The Raynaud's effect has only been picked up after the clinical trials. So if you have Raynaud's phenomenon, then it's important to tell your clinician that, because of the fact that a very small number of people, 1% of those people with Raynaud's, needed amputation because they developed gangrene as a result of this drug causing worsening of their Raynaud's. And some people had Raynaud's precipitated by it. And if you don't know what Raynaud's is, it's you get color, you get whiteness of the tips of your fingers and the tips of your feet, often in cold weather. They often go blue and they often go painful. So those are the monoclonals. The other group of drugs are the Gepants. And these have only just been approved by NICE for rollout in migraine. And you've probably seen all the hype and advertising about Vidura or Gepant. These again work on CGRP, but this time, instead of affecting the protein as it's in the tissues or at the receptor, it blocks a slightly different part of the receptor, and they're called CGRP receptor antagonists. There are 3 of them: Gepant, which I'll talk about, Gepant, which is coming next year, going through NICE, and Gepant. They're all different to the monoclonals. They're not necessarily better, but they're probably easier to be prescribed because they're tablets. They're here, and will you be able to get them? Probably, but it depends upon what's happening in your local area. And they're certainly going to be available to primary care more than these injectables are. I won't baffle you with the science, apart from to say that most of them are used as acute treatment. Some of them are used as preventative. And Gepant, which I'm largely going to talk about and answer some questions about, can be used both for acute treatment and for prevention, which has caused all kinds of confusion as to how we prescribe it. So can I get these drugs? Well, you can get Gepant because in July 2023, NICE looked at Gepant and stated that it was an evidence-based, cost-effective oral option for migraine prevention, in the same way as the other drugs. If you'd failed on 3 previous preventative treatments and you're having more than 4 migraine days a month, you could be prescribed this drug. You had to be assessed 12 weeks after starting it to see if you had a reduction in your migraine frequency by at least 50%. And it could only be prescribed for episodic migraine because there isn't sufficient evidence submitted to NICE on chronic migraine. These are the studies. Gepant led to about 50% of people having a 50% reduction in migraine. And the other drugs which are coming along showed similar responses, 50%. So again, it doesn't appear that this group of drugs are all very different from each other. It'll all be about tolerability over time. When you think about the previous drugs, if you remember, 40 to 55% of people with episodic migraine had about a 50% response. Gepant and Gepant appear to have a similar treatment response in terms of reducing the monthly migraine frequency by 50% compared to the monoclonals. So we don't really know if these oral drugs are better or worse because we haven't had a head-to-head trial, but they seem to have a similar effectiveness. And the same holds true in chronic migraine. 30 to 60% of people with chronic migraine, when given this oral drug, seem to have a beneficial effect. So these should be easier to obtain. They might be prescribable by a GP more quickly than the injectable drugs. So hopefully rollout will be better. So I'm just going to show you some data on its acute therapy. So if you've had a triptan for your migraine, or you have acute migraine, and you take Gepant, there's about a 1 in 5 chance that within 2 hours of taking your Gepant, you'll be pain-free. And then there's about a 40% chance that the most bothersome symptoms, so whether that be light sensitivity or noise sensitivity or smell sensitivity or nausea, will also be taken away. If you compare that to the triptans, it's actually a little bit worse. The triptans have been shown to work slightly more effectively in terms of giving 2-hour pain freedom compared to Gepant. Gepant's more expensive than the triptans. It costs £12.90 approximately for a tablet. And NICE looked at Gepant and felt that it was an effective treatment for acute migraine when used as an acute treatment, but actually it had to be used after triptans. So if you've used triptans in the past and you've found they're beneficial, this is not a new drug for you. If, however, you've tried at least 2 triptans and you haven't been a triptan responder, then Gepant is something that could be considered for you. If you have a condition that means you can't have a triptan for your migraine, such as heart disease or a stroke or a TIA, then triptans are contraindicated in those conditions and you could potentially have Gepant. It goes without saying that these drugs should be used if other medications haven't been helpful, such as over-the-counter non-steroidals or paracetamol. The other triptans, so the other Gepants that are going to come along, which you'll hear about as well, which are not yet available in the UK, is a Gepant, and you'll see again here 20% responder rate for 2-hour pain-free. And if you look at the other new ones which are going to come along, there's another one called Gepant, which is a nasal spray. You'll see, and I put a circle around all of them give an approximate 20% 2-hour pain-free. So the 3 Gepants that are going to be available for acute migraine probably don't differ that much in terms of their effectiveness. It'll all be about cost effectiveness and tolerability. So I hope I've left you with a little bit of a flavour of where we are in the United Kingdom in terms of treatment pathways for these new anti-CGRP monoclonals. If you see your doctor and you've had 3 preventatives, he's likely to refer you to a headache service or a neurologist, and then they'll have to make decisions about whether you have episodic and chronic migraine and whether you should have a MAB or a Gepant. If you have problematic constipation, you'll probably have to avoid something called a Raynaud. If you've got Raynaud's syndrome, we'd probably give you a Gepant before we'd give you a monoclonal. If you have latex allergy, you'll have to avoid a Raynaud. And if you have a high stroke or cardiovascular risk, this group of drugs may not be for you. And what does the future hold? Well, actually, there are other proteins. There's something called PACAP38, and there's something called amylin. So this journey in migraine through the 21st century has hopefully got new surprises for us. So keep your eyes on what's happening. And I'd like to say thank you to everybody for taking the time to listen to me, and I'm hoping we can answer some of your questions. Thank you to the Migraine Trust for inviting me.
Thank you, Brendan. That was really great. And thank you for the good discussions happening in the chat as well. It's great to see everyone talking to each other and giving advice. Just a reminder that the talk today is being recorded. There's been a few questions about access afterwards, so it will be loaded onto the our YouTube channel soon. So keep an eye out for that. And I'm going to turn you over to Steph now for some questions and answers. So feel free to put any questions you have in the chat and we'll keep an eye. Thank you.
All right, that's great. Thanks, Oscar. So one of the first questions that I've actually got is, can the triptans be taken with Gepant within the same 24 hours?
Yes.
They can.
Yes.
Okay,
so
that's perfect.
There's been studies with Gepants and triptans, and the answer is yes. They work on. They might be sympathetic to each other. So if somebody is taking, so the possibility is that the patients are prescribed Gepant, Vidura as prevention, which is taken every other day as opposed to daily. Or in the future, they might be given a Gepant, and they're being given that as a preventative, but they have an acute migraine. So then if they had a triptan responder, they would use that triptan in the same way. Now, there hasn't been any usage of one Gepant, like a Gepant, and then another Gepant as an acute treatment. So there isn't data on that, but actually there's no problem using triptans with Gepants.
Okay, that's great. I think that's probably really useful for quite a few people to know, actually. There's another question actually that came through. So you went about obviously the response rates to the CGRPs and Gepant, for example, but does it count as responding to it if the severity is reduced but the frequency stays the same?
So that depends. So that really depends upon your service. So if you stick to the letter of the NICE guidance, they're looking at a reduction in monthly migraine days. That's what they're looking at. They're looking at a 30% and 50% in episodic migraine reduction compared with baseline. What we do see is there are some people who've got something called chronic migraine with continuous pain. They have headache all the time with attacks of migraine on top. And what we see, the severity of background headache has reduced. The severity of their attacks has reduced by 30% or 50%, but actually their frequency of bad days hasn't reduced. What we tend to do in that situation is we give them another 3 months. So we don't just give them 3 months therapy, we give them a further 3 months therapy. So in total, they have 6 months preventable therapy in that situation. Because if there hasn't been a reduction in monthly migraine days by 6 months, we would argue that that drug is probably not fulfilling its potential, and we'd switch them to something else. So yes, we do look at severity, but actually, if severity alone over the shorter, longer term is only affected, we would say that drug isn't as effective as it should be. That's our service. I know other colleagues around the country may differ a little bit in that. Depends upon what level of care you are. If you've had every other drug and this is your last drug, you're probably going to be a little bit more soft in terms of looking at that outcome as you would be if it was only your third or fourth drug.
Okay, that's great. That's really useful to know. I think some people as well with medication overuse headache, for example, are told they have to stop all painkillers before they can go on to a CGRP treatment. Is that actually a necessary requirement, or is that again dependent on the service?
That's dependent on the service. You know, you need to challenge that. You need to go back to them on that. And well, the first thing I'd probably advise those people to do is pick up a copy of the short version NICE recommendations. It's on the NICE website. If you put in I'm sure the Migraine Trust on their website will have you put in NICE, you put TA, and you put the number, or you put in the name, and then read that. So medication overuse, and so stopping analgesics due to medication overuse is not mandatory with the anti-CGRP monoclonal antibodies. It is, you have to do that with Botox, but you don't have it to do it with the MABs. Now, it's good practice to suggest that people reduce their frequency of their analgesics if they can. But there are some people who have chronic migraine. They are taking triptans, say 16, 17 days a month, which is more than they should be. They should be about less than 10 ideally.
Yeah.
Their triptans are working. And what you find is you give them these drugs, their migraine frequency goes down, and their triptan frequency goes down. And that's been shown in all these studies. Because the mechanism is against CGRP, and triptans affect CGRP. So they don't have to, but they should try to.
Okay, excellent. That's great to hear, to be honest. I think we get that quite a bit on the helpline about people having to stop them before they can move on to other medications. So it's useful to know. Another query that we've had is about, yep.
What I would say, triptans, you don't need to stop. Opioids, so cocodamol, coproximol, codeine phosphate, morphine, tramadol, all those drugs which have got a morphine-based or an opioid-based, they have no place in migraine care. They just do not help migraine.
Yeah.
They make your brain more sensitive. They increase pain as opposed to reduce pain.
Yeah. Okay, that's really good to hear. With codeine-based medications, we know that they're probably more trouble than they're worth with migraine. With CGRPs and also the Gepants, can they lose effectiveness over time? So are they going to be, you know, less efficient the longer you take them?
Yeah, that's a really good question. There are some people where we see a wearing off effect. I couldn't give you a percentage for that yet. One of my colleagues has published some 2-year data from London seeing a wearing off effect in their population. I have to say the numbers wearing off are possibly 10 or 20% at 2 years. It's not a huge amount. We're still seeing people at 2 and 3 years on the same therapy having the same benefit and actually seeing increasing benefit over time. But we haven't got really good, robust data to be certain about that.
Okay, so it is really data-based, isn't it, with that kind of query? We've had a couple of questions actually about medications and stroke. So one of them was that a person was on fremanezumab for chronic migraine, had a stroke, then had to stop it, but can only take paracetamol now. And someone else has said they had a stroke and wondered if they can have the Gepants medications like a year on. What are the treatment options with someone that has had a stroke or had a stroke in the past?
Okay, so depending on the cause of your stroke, so if you've had a stroke, we probably wouldn't give you a Gepant or a monoclonal antibody for at least a year. But I don't think there's definite guidance in that. Gepants and monoclonals do not predispose you to stroke, do not increase your stroke risk. Because they work on, because CGRP causes vasodilatation, makes the blood vessels open up, which is a protective mechanism in stroke. The concern has been, is if you're on one of these drugs and you have a stroke or a heart attack, the safety mechanisms to stop it being a more severe episode are taken away. In rats, and I'm sorry to talk about animal models, in rats who had long-term CGRP given to them, and then a stroke was induced, they had a worse stroke as a result of it. That's why that comes along. But actually, once you're quite a long way from a stroke, say a year, some people might say 2 years, and you're stable and your risk factors have been addressed, then, and if you've had a cardiac disease and you've had stents put in, so you're probably safer than you've ever been, then there's no reason why you can't potentially be prescribed these drugs. They don't predispose you. They're just a little bit more challenging if you have one. We will probably give a Gepant first of all, because they have a short half-life and they're out of your body much more quickly, whereas the monthly injections, the MABs, they hang around. So we probably go Gepant first, and then if you're a responder and you wanted just a monthly treatment, MAB then.
Okay, that's great. Also, obviously, there's side effects to most medications. We've had a few people actually asking about the side effects for Gepants and whether or not they're similar to the side effects that the Triptans give. So things like chest tightness, insomnia, those kind of tiredness and things as well. Do we really know much about the side effects with Gepants yet?
Well, we do. Constipation is one of them. There are lots of CGRP receptors in your gut, and CGRP is involved in gastric motility, and so sometimes people see constipation with Gepants. Sore throat is a common thing. It's the same way as people get a Triptan chest or a Triptan feeling in their throat. Some people have that. They don't have the Gepants don't seem to have the same side effect profile as Triptans. I think they're better tolerated than Triptans. The one thing about the Gepants is some of them interact with certain drugs, so you have to be a bit more careful with certain drugs. Carbamazepine, if you have epilepsy, is one of the drugs it interacts with, and there's some antibiotics it interacts with. So you just got to be a bit more careful about other drugs you take with the Gepants. But the side effect profiles are all pretty good across the whole range of these drugs. Certainly not like topiramate and amitriptyline and all the things like that.
Okay, excellent. And do you know if the Gepants would be available for children at all, or is it 18 and above like the CGRPs?
18 and above at the moment, but they're doing studies in children, so it's likely that that will happen. I think there's been some concerns about use in children because bone health, really, just because sometimes CGRP, we're always worried about certain things which affect metabolic systems as well. So the American College of Pediatrics has given some guidance a little bit about Gepants if people want to look that up in children, but they're not licensed yet, and the studies are being done. So I think there's two things for Gepants in children. One, we've got to show that they work, and then two, we've got to make sure that they're tolerated before we start suggesting under 18.
Yeah. Okay, so it'll probably be a while before they are available for children then, by the time the studies and things and research been done into those. During the presentation, you mentioned about Raynaud's and some of the medications. A person's put that they are actually due to start Vyepti, but they suffer from Raynaud's when it's cold. Should they be worried? Is it okay for them to take it?
So it's not, they shouldn't be worried, but it's good clinical practice probably to mention that worsening of Raynaud's can sometimes occur with both Gepants and monoclonals. Now, the monoclonal, as has been described, infrequently. It's, this is not a common thing that we see, and we have patients with Raynaud syndrome who we give monoclonals to and have been totally fine. All we do is we have a discussion with them if they see a worsening of their Raynaud's following commencement of this medication, to let us know. The Gepants, there's 3 cases which have been reported with the Gepants in the world literature so far. So when you think about the numbers of prescriptions of Gepants that have probably occurred in America since they were licensed.
Oh. I think I've lost you, Brendan.
Brendan's frozen,
I think I've lost you, Brendan. We'll see if he can come back, but if not, we may need to end it there.
While we have a quick pause, I'll just do a couple of announcements. So just to let you know that we're running an Instagram live on Migraine at Christmas at 1 p.m. on Wednesday, the 13th of December. So keep an eye on, we've lost Brendan, unfortunately. So keep an eye on our Instagram account for